sir. Fast hug bid in ICU, tug test, Ferguson reflex, sir. Sir, shall I start, sir?
Yeah. Go ahead.
Yes, sir. First topic, fast hug bid in ICU, sir. One of the effective means of delivery of optimal care in ICU patient is by following a bundle care approach. One such effective care by fast hug bids. It is further modified into fast hugs bids PME, sir. What is this? It is a simple tool to assess the critical care patients effectively in a simple manner. Why we need this? To cover all the basics needs of the patients so that we won't miss out any needed things to the patient for daily care, and to improve quality of patient's care, increases safety and efficacy of patient's care, and encourages teamwork, sir. Uh, components of fast hugs bits PME. F for feeding, A for analgesia, S for sedation, T for thromboprophylaxis, H for head and elevation, U for ulcer prophylaxis, G for glycemic control, S for spontaneous breathing or supplement of oxygen, B for bowel movements, I for indwelling catheter, D for de-escalation of drugs, S for sore throat, P for positioning, M for morning care, E for eye care, sir. I'm going to discuss one by one, sir, component. First thing, feeding, sir. Critically ill patient and hypercatabolic patients becomes malnourished rapidly. This in turn leads to impaired wound healing and increased susceptibility to infections, organ dysfunction, and further loss of lean body mass, and leads to adverse outcomes. So it is one of the important in bundle to improve patients' outcomes, sir. What to check? By subjective global assessment form, which assess the nutritional status on admission or at least 24 to 48 hours of admission, and have to recheck every week. There are two types of feeding, sir. Oral feeding and parental feeding. Always have to prefer oral feeding if possible, and assure that head end elevation is around 30 degrees to avoid aspiration, sir. And gastric tolerance feed also should evaluate regularly, and feed should not be delayed for absent bowel sounds or high gastric residual volume. If not tolerable to oral feeds, then enteral feeding or through gastric feeds or jejunal feeds can be given, sir. This oral feeding helps in maintaining gut integrity of the patient, provides adequate calories to the patient. We have to give adequate nutrition with calories to 25 kilocalories per day, or on the carbohydrates 60 to 70%, fats 30 to 40% per day, and proteins 1.2 to 2 grams per kg per day, sir. Next topic, next component is analgesia and sedation, sir. Analgesia can be given in pharmacological and non-pharmacological methods, and can be preemptive or therapeutic, or can be regional or systemic, sir. First, pharmacological opioids and non-opioids can be given, sir. According to WHO ladder analgesia, for mild pain, non-opioid with or without adjuvant therapy. For mild to moderate pain, weak opioid with or without non-opioid, and with or without adjuvant therapy. For moderate to severe pain, strong opioid with or without non-opioid with or adjunctive therapy, sir. Opioid have to be preferred mostly, sir, because high potency and time of onset is short and duration of action is short, with the minimum side effects of cardiorespiratory depression. Example, fentanyl and remifentanil. Non-opioids like acetaminophen or NSAIDs, and non-NSAIDs like ketamine and Dexmed are some of the medications in non-opioids, sir. And regional techniques like epidural nerve block, plexus nerve block, peripheral nerve block can be given for analgesia, sir. Next component is thromboprophylaxis, sir. According to Virchow triad, DVT components DVT occurs with the three components, sir. Hypercoagulability state, vascular damage state, and the circulatory stasis. Hypercoagulability conditions like malignancy, major surgery, trauma, postpartum pregnancy, and in vascular damage conditions occurs in conditions like cellulitis, thrombophlebitis, and atherosclerosis and heart valves. Circulatory stasis occurs in immobility patients, venous obstruction conditions like obese, tumor, or presence of tumor, or in pregnant female. Varicose veins, low heart rate, and low BP. Strategies adopted for the prevention of deep vein thrombosis. There are two types of prophylaxis, sir. Primary prophylaxis and secondary prophylaxis. Primary prophylaxis is adapted to prevent DVT with a chemical or mechanical prophylaxis, sir. For secondary prophylaxis, mainly for is early detection and treatment of subclinical DVT by screening with objective tests that are sensitive for presence of DVT, sir. First, primary prophylaxis. In primary prophylaxis, chemical prophylaxis, sir. Ultra fractioned heparin, 5,000 international units subcutaneous twice daily. Low molecular weight heparin like enoxaparin, 30 mg subcutaneous once daily. Delta parin, 5,000 international units subcutaneous once daily, sir. Next, fondaparinux, 2.5 mg subcutaneous once daily, which is having 100% bioavailability, and T off is 17 hours, sir. Newer agents like dabigatran, iveraxaban, and apixaban can also be used, sir. Mechanical prophylaxis to prevent DVT is sequential compression device, venous foot pump, stockings, and early mobilization also one of the mechanical prophylaxis to prevent DVT, sir. Next component is head and elevation, sir. Why we need this? To prevent aspiration pneumonia. Head and elevation should be keep around 30 degrees to 45 degrees, but major setback is increases chance of pressure ulcer in the sacral area in high risk patients. Actually, aspiration occurs with oropharyngeal secretions and or gastric contents. Neurological status and the ability to cough reflex, feeding, and GI motility play an important role in aspiration, sir. Response depends on quantity, or duration and type of aspirate. So, patient may be asymptomatic or may develop chemical pneumonitis or infective pneumonia. So, in high risk patient, we have to give a head and elevation 30 degrees to 45 degrees. In low risk patients, around 30 degrees is enough, sir. Head and elevation is contraindicated in hemodynamic unstable patient, in pelvic fracture patients, and spine fracture patients. Next component is ulcer prophylaxis, sir. This ulcer prophylaxis is much needed as stress-related ulceration of upper gastrointestinal tract, known to be critical illness, sir. Clinical manifestations may be from asymptomatic to severe GI bleeding, sir. Incidence around 4% in all critically ill patients. There are therapeutic options to prevent for ulcer prophylaxis, sir. Nutritional therapy, optimization of hemodynamic state, H2 receptor antagonist like ranitidine, and potassium pump inhibitors like pantoprazole, antacids can be used, sir, for ulcerative prophylaxis. But on using of ulcer prophylaxis therapy for long time, leading to some complications like GI upset, headache, interstitial nephritis, Clostridium difficile enterocolitis, sometimes pneumonia may occur, sir. And also associated with complications occurs are hypomagnesemia and hypocalcemia. So daily assessment to be done to prevent adverse effects, sir. Next, glycemic control, sir. Next component. Among critically ill patient, abnormal blood sugars are common, so more possible to develop hyper and hypoglycemia, lead to increase mortality rate and organ damage. So hyperglycemia is significant if GMBS is more than 200. Hypoglycemia is significant if GMBS is less than 40 to 50. Moderate hypoglycemia is less than 70 milligram per deciliter. So normal range should be keep around 80 to 110 milligram per deciliter, sir. Recommended in for a critically ill patient in ICU is around 140 to 180 milligrams per deciliter, sir. How to manage? Start with short-acting IV insulin is a drug of choice for infusion during initial phase. Once disease severity reduced and glycemic control is better, switch over to subcutaneous route. Avoid long-acting insulins and uh, oral hypoglycemic agents in critically ill patients. Care should be taken in potassium supplements while on insulin infusion, sir. Next component is spontaneous breathing. Uh, it is two types in medicine and in surgical ICU, sir. Spontaneous breathing in medical ICU and supplemental oxygen in surgical ICU, sir. What to do? Several studies have proven in early weaning and sedation in early weaning sedation interrupt to be done. Likewise, deep spontaneous breathing trial wherever appropriate significantly. Cut down number of ventilator and ICU phase. Combining with daily sedation interruption with spontaneous breathing trial will be most effective strategy toward liberation from mechanical ventilators, sir. Going to next component, bowel movement, sir. In what we have to see in bowel movement, patient having constipation or diarrhea. Constipation having more than 3 days, and diarrhea maybe is like 2 to 3 liquid stools per day, or more than 250 grams of liquid per day. We have to look, sir. Whether in diarrhea, again we have to look out either it is infective or non-infective. Most commonly is non-infective, sir. It is due to feed intolerance or oral medications like laxatives, potassium chloride syrup, and phosphorus supplements. And infective most commonly due to Clostridium difficile and antibiotic associated diarrhea. Again diarrhea is classified into secretory or osmotic, sir. Secretory is infective etiology and osmotic is non-infective etiology. Uh, that test to be done to differentiate the secretory or osmotic is stool osmolar gap, which is a difference of measure osmolar gap and calculated osmolar gap. More than 100, it is osmotic diarrhea, sir. Management, feed should not be stopped. Instead, we have to add soluble fibers and semi-elemental feeds for the proper bowel movement, sir. Uh, constipation, what are the causes like opiates, dyslipidemia like hypokalemia, ileus, Clostridium difficile, and intestinal obstructions, sir. We have to manage constipation with by treating metabolic causes like hypokalemia, hyperglycemia, and withholding naloxone or opioids. And in if appropriate condition, we can use laxatives also, sir. Next component is indwelling catheter, sir. Commonly used in critically ill patients, used for diagnostic, monitoring, or therapeutic purposes. Commonly used are central venous catheter, dialysis catheter, arterial catheter. Others, Foley's intercostal drains, surgical drains, lumbar drains, ET tubes, feeding tubes. Daily evaluation have to be made regarding the continued need for these lines, and when no longer needed, they should be promptly removed in order to prevent infections. Next component is de-escalation of drugs. What we have to check in this component is antimicrobial therapy is the common and frequent therapeutic strategy in critical care areas, leads to poor clinical outcome because of rise in antibiotic resistance. So prevent to use optimal use of antibiotics, which reduces unnecessary health care. Hospital antibiotic stewardship program and infection control teams generally monitor for usage and de-escalation strategies. Next component is sore pressure, sir. What to check here is risk assessment of the skin by scale, Braden scale, sir. And when we have to check at the time of admission and at daily reassessment, sir. Next, I have to assess healing scale, healing scale of the pressure sore. That is push scale. If ulcer is present, we have to use push scale. If a pressure ulcer is not not present, then we have to use Braden scale, sir. What to do to prevent bed sores is daily assessment and proper care, like putting the patient on alpha bed, dressing regularly, and providing adequate nutrition, sir. Next component which is modified, having positioning, sir. What to do in this is changing a patient position in bed every 2 hours helps keep blood flowing, helps the skin stay healthy and prevent bed sores. By turning a patient in a good time to check the skin for any redness or sores, sir. Next is morning care. What to do is morning bed bath, mouth care, mouth care with chlorhexidine, changing of tubing and dressings, and thorough skin assessment, sir. Next, last component is eye care, sir. Health of the eye, eye front surface, that is cornea, depends upon the ability to produce tears, to blink, and ability to close the eyes and with during rest or sleep. In ICU, these can be impaired whether by diseases like facial edema, decreased conscious level, peripheral or central neurological injuries. So clean the eye regularly, apply moisture creams, and close with packs which protects the cornea, sir.
Okay. The first and foremost thing, when the question is given as an acronym, you can write that it is the acronym for the points that should be taken care of in patients who are in critical care, either under critical situation or under surgical. And we only passed the DID. The last two things about pressure sore, health care, all that. So which category you have included?
Okay, sir.
So just to the question that has been asked, you can stop with theory, you can't be utilized, but about not writing it on the eye care or the physical care.
Okay, sir.
And 2 points which I noticed you can add that feeding apart from providing calories, it also prevents the translocation of the bacteria. Okay? That is very important. That's why we insist on starting enteral feeding as early as possible.
Okay, sir.
Then coming to the ulcer prophylaxis, we have to mention about sucralfate. It's
Sukral.
found
Okay, sir.
there. Nowadays they give prostaglandins also, which is
Okay,
deficient, which causes ulceration. So these
okay,
two drugs are given to prevent as well as cure the
okay, sir.
or the internal ulcer, the form or the stress that
Okay,
otherwise
sir.
all the points they have written are very sufficient for this. It is as such a partner thing, you should be able to concise and write it fast without
Okay,
exaggerating too much on the drug use for prophylaxis. All that can be different and can just mention anticoagulants like heparin or local heparin can be used for prophylaxis and mechanical support of blood stopping things can be used. So that
okay,
can
sir.
save time.
Okay, sir.
Otherwise, it's very well written.
Okay, sir.
And
Shall I move on next